Okay, hi everyone. My name is Carol. I'm a first-year cardiology fellow, and I'm on my first echo block. So I thought it would be a good idea to talk about overnight on-call echo assessments because this is pretty pertinent to all of us as cardiology fellows. So it will be a case-based discussion, so I'm hoping for a lot of participation. And we'll go over some echocardiographic features of interesting cases and things to look out for on echocardiogram. So thanks for joining today. So just in terms of our objectives for today, so we're going to identify clinical situations that require urgent echocardiographic assessments, and this will be done by case-based discussion. So we'll give you a case, we'll review the echo, I will ask someone to describe what they see on the echo, and then we'll describe just briefly a bit of the etiology and management. We'll also describe echocardiographic measurements that can aid in clinical assessment, particularly overnight in urgent situations. And then we're going to review some pathology identified on echo that require intervention, so usually more urgent intervention, and what the next steps will be. So I don't have any disclosures, but a caveat is that this is my first echo block, so I'm still learning. So if there's any questions or comments that anyone wants to add, I'm very open to hearing them. Okay, so we'll just start with our first case. So we have a 56-year-old female who's intubated in the ICU. She's been intubated for 3 days and she has COVID. She's worsening from a respiratory perspective and has decreased urine output. And her laboratory results show that she has an increase in creatinine and lactate. So the ICU are asking you to perform a bedside echo. And so on the next slide, we have an echo. And I hope this works. And if we cannot see the videos, please let me know, but I think this should work. So we have, I'll do the first video on the left. And then on the right. And so I can repeat those videos, but if I can get someone to either unmute themselves or to type in the chat to describe what they see. So they don't have to have a diagnosis, but maybe just starting with which views we're seeing and any striking things that were, or striking abnormalities in each of the echoes. So I might pick on some of the cardiology residents.
So please volunteer and also type it into the chat box, please. Thank you.
Yep, so we have a 3-chamber view, 2-chamber view on the right, and as Taylor's saying, we see a wall motion abnormality. And Taylor, where and Dr. Goffey is saying stress cardiomyopathy, too many TLAs, hypodynamic basal function. Oh, too many 3-letter acronyms. So everybody is correct. So on the left, we have a 3-chamber view, and we see that the left ventricle is quite dilated with wall motion abnormalities, particularly in the apex. And then on the right, we see a 2-chamber view showing much of the same. And this is consistent with stress-induced cardiomyopathy or Takotsubo. And just on the next slide, oops. So we see some features again, global decrease of left ventricular function with apical akinesis. And so this is consistent with Takotsubo cardiomyopathy or stress-induced cardiomyopathy. So just a few points on Takotsubo cardiomyopathy. So there's regional wall motion abnormalities, as everyone rightly pointed out, but they extend beyond a vascular bed, so beyond one vascular territory. So that can be an indication that this is Takotsubo or stress-induced rather than due to ischemia or infarction. And usually when we do like coronary angiography, there's no coronary artery occlusion, but it's an important step to conduct because it's on the differential for a presentation such as this. It's often preceded by a physical or emotional stressor. So if somebody is, let's say, not in the ICU, there tends to be something that causes the acute stress. And the pathophysiology is thought to be related to catecholamine excess. And there's a comment in the chat, do you think the worsening renal function and increased lactate could be explained by the cardiac findings? I think so, and I think that's why I put that in the case. And so that would have been the prompt to do the echo in this case. Sorry, there's another comment in the chat. Also seen in trauma ICU and transplant donor. Yeah, most acute illnesses, I think, can be risk factors for the stress-induced cardiomyopathy. And we're often called on the weekends. Yeah, perfect. So good to go over. So in terms of the different variants of Takotsubo or stress-induced cardiomyopathy, so in this case, it's an apical variant where we see apical hypokinesis but preserved basal function. But there are other subtypes, so midventricular, basal, and focal. So this just alludes to the area that has hypokinesis, and these are just diagrams to show where the hypokinesis occurs. But the most common is the apical view, and that's the Takotsubo. That's what it's named for. It's a type of pot, I believe, a Japanese pot. And so briefly, we're not going to go into too much detail on management, but just briefly next steps. So you do want to assess for ischemia because although it's consistent with stress-induced cardiomyopathy, you always want to rule out ischemia. Oh, thanks, Fotis. It's a special pot for catching octopi. You also want to assess for left ventricular outflow tract obstruction. So in particularly with the apical variant, with the basal that is still moving, there can be left ventricular outflow tract obstruction. And so for this reason, it's important to use care with using inotropic agents because this can worsen the left ventricular outflow tract obstruction and can also contribute to the pathogenesis. Also, usually these patients recover, but consideration of mechanical support therapy if they have refractory shock is important. But as I said, the prognosis is usually quite good. They do usually tend to recover. And so just briefly, because this is my first echo block, I thought it would be useful to go over the assessment of the left ventricle. So overnight and in urgent situations, we usually use a qualitative assessment. So just generally, is the left ventricle down, or is it contracting, or is it hyperactive? But you can use some echocardiographic measurements for a quantitative assessment. And so this, I'll put this out to the crowd either through chat or unmuting. Can somebody give me the equation for cardiac output?
So there are two determinants to cardiac output, Carol, that I can think of in my mind. One of them is heart rate, and one of them is stroke volume.
Perfect. Thanks, Fotis.
No worries.
So that is very correct, and an important equation to remember. And just looking at the next slide, so we can measure cardiac output with echocardiographic parameters. And so heart rate we know from physical exam, but the stroke volume we can measure with echocardiographic features. So the equation for stroke volume as measured by echo is the time velocity integral multiplied by the cross-sectional area of the LVOT. And so the time velocity integral you can measure by using a pulse wave Doppler at the center of the aortic annulus, and you can see where it is on the left image. So that's where you would place your pulse wave Doppler, and then with the pulse wave measurement, it's the area under the curve, and that's how we would get the time velocity integral. And then to calculate the stroke volume, you can look at the diagram on the right, and I thought this was a good picture representation of, you're really just calculating the volume of a cylinder. So the cross-sectional area of the LVOT multiplied by the time velocity integral, and that gives you the stroke volume. So I thought that was a good way to sort of conceptualize in your mind how to calculate the stroke volume and cardiac output. And then just for reference, the LVOT. So you measure the LVOT within 5 millimeters of the aortic annulus, and it's measured with the anterior cusp, measured where the anterior cusp meets the ventricular septum to where the posterior cusp meets the anterior mitral leaflet. And so this is the diameter, and you divide that by 2 for the radius, and the LVOT surface area is pi r squared. So back to mathematical basics. Okay, so we'll go to the next case. So there's a code blue called overhead in the emergency department. 10 minutes later, there's an overhead call for cardiology to go to the emergency department stat, and the emergency doctor is asking for an echo. So this is the echo. So can I get someone either by unmuting themselves or in the chat to describe what they see?
It looks like there's a circumferential pericardial effusion, and there seems to be inversion of the right atrium. And I'd have to confirm by going a little slower at the through the cardiac cycle, but there may be impaired RV diastolic filling and maybe some RV diastolic collapse.
Perfect, thanks, Jonah. So correct, so we can see in both of these views that there is a circumferential pericardial effusion. And as Jonah rightly pointed out, there is evidence of both RA and RV collapse. Yes, tamponade, thanks, Patrick. We don't have a view of the IVC right now. Another common reason for on-call study, thanks. So was it full? It was definitely full in this case. It was definitely full. I just didn't include it in these views. So some echocardiographic features of tamponade, as everyone rightly pointed out. So there's right atrial inversion, particularly during late diastole. So this is an early but non-specific sign. It lasts over 1/3 of the cardiac cycle. And then you have also RV collapse in early diastole. So we see both of those things in this case. You can also get left atrial chamber collapse, and then interventricular septal shift with increased venous return. And so the interdependence. And so the most sensitive echocardiographic features of plethoric IVC, as Dr. Goffey rightly pointed out, and the most specific is actually left ventricular collapse, but this is usually a late sign. So we see the majority of those features in this case. So in terms of tamponade for quantification, so we use mild, moderate, and severe when looking at the size of the effusion. So mild is less than 10 millimeters, moderate 10 to 20, and large over 20 millimeters. But the hemodynamic compromise definitely depends on the acuity. As with rapid effusions, you reach the point of critical tamponade earlier with volume, with the pressure increase, whereas if there's a slower effusion, the pericardium has a bit more time to accommodate. So it takes a bit longer and a bit more volume to reach the point of critical tamponade. And the management, of course, is urgent pericardiocentesis, particularly if there's hemodynamic compromise. Okay, so next case, case number 3. Code blue is called overhead from the surgery floor, and 15 minutes later, there's an overhead call for cardiology. And medicine is asking for a bedside echo. Okay, can I get either a volunteer to unmute or someone to type into the chat what they are seeing? I'll just put these on repeat. Perfect, thanks, Sean. RV midwall dyskinesia, consistent with a PE. Perfect. Moderate to severe dysfunction of the RV. Was this patient on a trans-Pacific flight recently? Maybe, and then they went straight to surgery. So yes. So we see here in the parasternal long view, there's RV dilatation, particular. And this is a 4-chamber view with a view to emphasize the right ventricle. And we can see again, right ventricular dilatation with decreased systolic function. Dr. Goffey, in the MSICU, we often see patients who come hypovolemic and have chronic effusions and now RA collapse. IVC is often critical to suspect hypovolemia with fluid resuscitation. Often the echo features of tamponade disappear. Thanks, Dr. Goffey. Yeah, good pearl for real life situations. So for case 3, just some of the echocardiographic features that are suggestive of a pulmonary embolism, as Sean correctly pointed out. So you can get right ventricular dilatation, right ventricular dysfunction, RV free wall hypokinesis. So hit the nail on the head, Sean. You can sometimes have visualization of a thrombus and septal flattening in addition to paradoxical septal movement. And then you can have a hyperdynamic LV. We didn't see the PA view, but you can have PA dilatation. And then McConnell sign is right ventricular free wall akinesis, but sparing of the apex. So this is a specific but not sensitive sign, but we actually see this in this case. I'll just go back to this view. So we can see that there's decreased right ventricular wall motion, but sparing of the apex. And then management, of course, is thrombolysis if hemodynamically unstable. And then just briefly, talking about assessment of the right ventricle. So there are different ways that we can assess the function of the right ventricle. So one of them is size. So we do measure the right atria, and normal volume is less than 33 mils per meter squared. And then in terms of the right ventricle, we also do measurements to assess. Usually we use the basal RV diameter, and this is measured in the apical 4-chamber view and measured at end diastole. And there are other measurements we use, but we usually use the basal RV diameter. And at the bottom, we just have a reference for the normal values. And then in terms of assessment of right ventricular function, we use the RVS prime. So it's, normal is over 11 meters per second. And then the TAPSE, or the end excursion of the tricuspid valve. And normal is over 17 millimeters. And then we also calculate the fractional area change, and normal is over 35%. So just, this is more for my reference to learn the assessment of the right ventricle. Okay, so we have case 4 now. So there's a patient in ICU who is having hypotension, is on maximum dose levofed, vasopressin, and epinephrine, and you are called to perform an echo. So on the next. So this is, it's a bit more subtle in this case, but if I could get someone to either unmute or type in the chat what they'd see, I will just put these on repeat. Maybe some of the more experienced echo fellows can describe what they see. Subaortic membrane. I'm not sure. I don't think we see that necessarily. I'm not sure if that terminology is used to describe what we're seeing. Dr. Goffey, give fluids and switch to phenylephrine. So correct. Feel free to answer, or you can give hints to the other echo fellows.
Yeah, is the concern here HOCM?
Not HOCM, yes, but more so LVOT obstruction, exactly. So here we see, it's a bit subtle, as I said, because I didn't put color, but there's quite a narrow LVOT, exactly. And so here I just wanted to go over some echo features that would suggest a hyperdynamic LVOT or just LVOT obstruction, basically. And so we see systolic anterior motion of the anterior leaflet, and you can have subsequent MR. I didn't put color on the previous echo slides, but you can have that. But the key is the very narrow LVOT and then the gradient that you measure. So you measure it in the 5-chamber and 3-chamber views, and then a gradient of 30 millimeters of mercury is significant. and over 50 tends to be hemodynamically significant. And one of the things that can be also suggestive, in addition to the narrow LVOT, is if you do continuous wave Doppler, there is a dagger shape in the continuous wave Doppler that is suggestive of LVOT obstruction. The more I scan in the ICU patients in shock, the more I find it is more common than we think in early phases of resuscitation. Yeah, so really important to identify, because the management can differ, or it does differ. And on the next slide, actually, I'll throw it out to the crowd again. So some etiologies that can contribute to dynamic LVOT obstruction. So Jonah mentioned HOCM, which is definitely one etiology that can cause LVOT obstruction. Takotsubo, as we mentioned earlier, so particularly the apical variant, that's correct. Anything else that anyone can think of too important to keep in the back of our mind? Anterior MI, exactly, Ryan. So anterior MI as well. And then so there are some anatomical variants of normal that can contribute. Anyone care to mention any sort of anatomical variants? That hyperdynamic states, exactly, Patrick, and small ventricles, exactly. In particular, people with a sigmoid septum as well. Also, some people can have abnormal papillary muscle configuration that can contribute. So great job, everyone, in identifying potential contributors to LVOT obstruction. And so, as Dr. Goffey mentioned, management of hyperdynamic LVOT obstruction, it's really important to recognize, because the management completely changes. You want pure alpha agonism in order to increase or decrease, basically, the LVOT obstruction. So phenylephrine, whereas inotropic agents can worsen the obstruction, because it can worsen the, or increase the myocardial contraction. Okay, so case number 5. So we have an 84-year-old female with a history of hypertension and dyslipidemia. She had chest pain 3 days ago, which is since resolved. She has a troponin that's elevated, and ECG shows Q waves. And so we have the echo. Dr. Goffey, we see it often in patients with a history of severe hypertension and end-stage renal disease. When we are trying to aggressively ultrafiltrate them and facilitate weaning from the vent, they develop LVOT obstruction during dialysis. Yeah, because I guess with the fluid shifts, right, Dr. Goffey, makes it a bit difficult. So the next case, bedside echo. We'll play that again. And so can I get somebody to either in the chat or to unmute to describe what they're seeing here? So 84-year-old female, chest pain 3 days ago. A bit of dyspnea as well. Anyone?
Yeah, so it looks like we're in a peristernal long axis view here, and we're zoomed in kind of on that mitral valve. And then if you play that mitral valve loop on the left once again, you can see that there's clearly a flail leaflet. So the leaflet here is actually pointing towards the left atrium. On the right, the Doppler spectral profile suggests torrential, well, not torrential, but severe MR. Torrential is more for the right side.
Perfect. Thank you, Fotis. And in the chat, we see posterior leaflet flail with severe MR. Flail versus cord rupture and massive MR, correct. Perfect. So here we have MR as a mechanical complication of a myocardial infarction. So as everyone rightly pointed out, thank you, Fotis. So in the in the peristernal long, we see that the mitral valve leaflets, in the posterior leaflet, there was an oscillating mass pointing towards the atria, suggestive of a flail. And then on the color Doppler, we see the jet of MR. So it was quite severe. And with the posterior papillary muscle rupture, it was directed anteriorly. Partial flail with the posterior MV leaflet, since the tip is still pointing to the LV side. Okay, so partial flare, I guess, because of where it was pointing. I thought it was pointing in the atria, no? You can see again. Would that be partial? I'm not sure.
So if the leaflet is completely pointing into the left atrial side, then all the supporting structure is gone, then it's actually complete flail. So it's just a terminology.
Okay, good to know.
It's actually still not entirely pointing to the left atrium. So this is just a terminology, but there's going to be substantial MR because of the gap.
Perfect. Okay, thank you so much. Okay, so the echocardiographic features we've gone over, and then just some background information. So mechanical complications of MI. So MR is a complication. So there are some risk factors. So older females, history of heart failure, first presentation of MI, and then delayed presentation in addition to thrombolysis. The incidence is quite low, but important to recognize because it drastically changes management. And in terms of vascular supply, so there's a singular blood supply to the posterior medial papillary muscle, so it's supplied by the PDA, but depending on dominance, this can be supplied by the left circumflex or the RCA. And because of the singular blood supply, it's more likely to rupture than the other papillary muscle. So this can be due to inferior or lateral STEMIs, depending on the dominance. So there may not be a prominent murmur on auscultation, and this is due to equalization of pressures and decreased velocity of flow. And it usually happens within days of the MI. And then important in terms of management, you want to decrease the LV afterload. You want to give pressors as necessary, and then you, depending on the situation, will want to give temporary mechanical support. And usually this is an aortic balloon pump, but quite a high mortality, and the management is urgent surgery.
Carol, just a comment on that one.
Yeah.
To my eye, the posterior leaflet looked quite long.
Mm-hmm.
And to me, that actually looked more typical of a myxomatous mitral valve with a flail segment. So I accept that you can have both, that you could have a ischemic papillary muscle dysfunction in the setting of somebody who has myxomatous mitral valve, but without the history, I would have said this was mitral valve prolapse with probably a flail, chordal rupture, causing severe MR. With papillary muscle rupture, you actually can see the head of the papillary muscle flipping around in the left atrium, and this is clearly not that. Okay. You could have ischemic papillary muscle, which is not totally ruptured, which then results in a sort of the posterior mitral leaflet not being supported, and therefore again acute severe MR. But this one actually looks a little more like mitral valve prolapse, frankly, to me, than a typical normal valve with a papillary muscle rupture.
Thanks for pointing that out, Dr. Howard. I just pulled it from the Black Echo book, and it said that this was a papillary muscle rupture, but you may be right. Maybe it was denoted incorrectly. And to my eye, I might not have noticed.
Yeah, Carol, I'll just add to that. So I completely agree with Bob. I mean, just looking at these pictures, it can go either way. But that's where the story is very important, and knowing the whole story when you're doing the on-call echo, and knowing which territory is involved, which ECG, what are the ECG findings that goes with it, troponin, and also having special views to look at the papillary muscles. So some of the special views that we would use is actually apical two-chamber that's actually aimed more posteriorly, as well as the short axis will interrogate through the short axis up and down to actually look for papillary muscle. So it's a heightened sensitivity to look for actually the papillary muscle structure. I've actually been screwed throughout my career that I would just identify these with like without knowing the history, just reading echo like this to just identify the prolapse and MR, but not recognizing that the papillary muscle is partially dehisced or actually completely broken later on in a few days. So those are the things to where the clinical stories becomes very important.
Perfect. Thank you very much, Dr. Chow and Dr. Howard. Important to note. And yeah, I I think in this case, I'm not sure in terms of the actual clinical history. I did make up some of the components of the case to fit my presentation, but important to note in terms of the differences. Thanks for pointing out. In terms of the next case, so case number 6, so along the same lines, 84-year-old female, history of hypertension, dyslipidemia, chest excuse me, pain ongoing for 3 days, now presenting with severe dyspnea. And so again, there's only 2 views here. And again, a little subtle, but I'll play them on repeat. And if anybody wants to either unmute or type in the chat what they're seeing. Basal inferior septal VSD. Thanks, Ryan. So here we see with the color that we can see that there's flow from the left ventricle to the right ventricle, and in the right-sided image we can see that there's actually the VSD. We can actually see the VSD in the basal area. Thanks, Ryan. And so some echocardiographic features of a VSD, and in this case, again, it's a mechanical complication of a myocardial infarction. So basically, all you're seeing with the color Doppler is flow from the left side to the right side. And so in the different views, you'd be able to see this flow. And so again, a bit of background. So incidence is low, but again, important to recognize because it's an urgent surgical indication, depending on how much in shock the patient is. And it occurs in anterior and apical myocardial infarction, so 70% from the LAD territory and 30% in the RCA territory. So the basal septal VSDs usually occur with the RCA infarcts. It can be accompanied by MR, and then the management is similar. So afterload reduction and urgent surgical repair depends on the shock state. And then a very high mortality as well. Okay,
Carol,
so moving
can I just
along.
add that the last 2 things that you discussed are one of the primary reasons, amongst other things, but one of the primary reasons why we auscultate patients who are presenting with acute MIs, to evaluate if they have any hemodynamic effects that are either a VSD or ischemic MR. So it's important that, you know, the echo images are pretty, but this is practically very important, you know, for our day-to-day work, especially in the CCU.
Perfect, thanks, Fotis. Thanks for pointing out. Completely agree, because it drastically changes the management. Perfect, so next case. So again, another code blue in emergency, and then there's an overhead call for cardiology in the ED stat. And so this case, it's not a video, but we can see here, can somebody describe what they see here? Going along the same lines as the previous cases. Perfect, thanks, Sean. So RV free wall rupture. So this is again another mechanical complication in a pericardial hematoma. So another mechanical complication of a myocardial infarction. Big problem, thanks, Otis. And so some echocardiographic features include tamponade if there is frank bleeding in the pericardium, but you can also have a pseudoaneurysm or aneurysm if it's contained within the pericardium. And so these tend to be inferior lateral walls, and it may not necessarily be as acute if it is a pseudoaneurysm or aneurysm, but you would see on the color Doppler, there's flow across the defect. Thanks, Dr. Shao. And so usually these are very bad. Incidence is not really well known because a lot of them probably die prior to getting to hospital. But some background facts, so 3 to 5 days post a transmural infarct. And some risk factors include delayed reperfusion and ineffective reperfusion. And then management is urgent surgical repair and mechanical support in the interim. Very high mortality for the cases that we are aware about. Okay, case number 8. So we have a 51-year-old male with a TIA. Medicine asks for us to do an echo. So this is a bit less context, maybe not as urgent overnight in terms of an echo, but we'll go over it. And so we have 3 views here. I'll just play them on repeat, and if anybody wants to either unmute or type in the chat what they're seeing. CCU room, large LV thrombus. Thanks. What else is evident in terms of the echo, in addition to the thrombus? Like what is the etiology of the thrombus? Perfect, thank you. So apical hypokinesis. And so which territory are we thinking is causing the hypokinesis? Which vascular territory? Does anyone want to type? We can go to the next slide. LAD, perfect. Thanks, Patrick. Okay, so this case I just wanted to go over, just to briefly go over regional wall motion abnormalities by vascular territory, because I think it's an important, it's important to know, especially when we're doing overnight echoes, to assess for potential NSTEMIs, and just to understand the vascular territory in each of the echo views. And so here, this is just pulled directly from an article, but I blocked out the vascular territories. And so the dark blue, can somebody either type or unmute themselves and tell me which vascular territory corresponds to the dark blue in these diagrams? Perfect. Thanks, Ryan. RCA, great. And then the green. So the green here, the light green. Perfect. And then the last, of course, would be the circumflex. So I just thought that this was important to go over, and as a review for myself. No cheating, Patrick. Yeah, it's literally right in front of you. And so there are some territories that can be, depending on anatomical variants, supplied by either, but for the most part, it's good to have a reference in the back of our minds of the vascular territories and what walls they correspond to when assessing for regional wall motion abnormalities. Okay, so case number 9. So we have a 35-year-old male with a history of hypertension who presents with chest pain, referred to cardiology for query ACS. So the echo. So we only have one view, and again, if somebody can just describe what they see.
I'd like to put all my money on dissection.
Jonah, how all your money?
All in, all in.
Okay, okay.
I hope you didn't get loaded.
Well, how about, can anyone describe what they're seeing here in this echo view?
I think we can see the ascending aorta on the bottom right. And I'm not 100% sure if this is maybe a parasternal short, and that's the RA we're seeing in the bottom left and the RV in the top left. And certainly the aorta in the kind of right side of the screen, it looks like there's a double lumen, kind of pulse lumen waving back and forth.
Yeah, exactly. So I actually agree with you. Maybe some of the echo fellows / staff, because the black book said that this was a TTE, but so in that case, I feel like this might be a parasternal short, but I'm not actually, if somebody can maybe input, I'm not sure if this actually is a parasternal short or not. I'm not sure if anyone else has an idea, but you can definitely see the flap of the lumen waving back and forth.
And then there's,
I think it's an off-axis like view of the aorta in a long. I think it's kind of
in the long
a little bit, yeah.
Sorry, parasternal long. Yes. Okay.
Yeah, it's a parasternal long,
sense.
slightly off axis. It's probably tilted a little bit
Okay.
towards short. So, but yeah.
Okay. Perfect. Thank you so much. But we can definitely see the dilatation and the free flap. And the Patrick, yeah, thanks. The image is distorted due to the pathology. Okay, so as everyone rightly pointed out, so this is an echo of an aortic dissection. So we can see the presence of an intimal flap separating the true and the false lumen. The false lumen may have some flow when assessed by Doppler, but sometimes it doesn't because it can be thrombosed. And the sensitivity and specificity with a TTE in detecting an ascending aortic dissection is approximately 93 to 90, and the specificity is 97%. But there can be some artifacts that can contribute to an assessment of a potential false lumen that are incorrect, and these include reverberations of the left atria, in addition to the posterior wall of the right pulmonary artery. And in order to assess this, you can use M mode to try to help distinguish. And so just for reference, I wanted to show the same type of clinical picture with a TEE just to see what it looks like. So we can clearly see here that there's the free flap floating, the TEE, which is a bit more sensitive and specific in detecting ascending aortic dissections. And so just again, a brief overview, this should or is review, but the type A and type B aortic dissection, so type A would be ascending, and those are acute surgical emergencies, whereas the type B, the descending, are medically managed. And if one, I think I have on the next slide, so if a patient has an aortic dissection that's ascending and they're hemodynamically stable, they can go for CT angiography to further characterize. Whereas if they're hemodynamically unstable, it's an urgent OR indication. In addition, the TEE is usually done in the OR. Okay, so this is case 10. So this is the last case. So we have a 58-year-old male. He's a known mechanical mitral valve. He's presenting to the emergency with fevers and chest pain. And you are asked to do an echo. And so I'll just play these sort of on repeat if anybody wants to either unmute themselves or type what they're seeing. Rocking, perfect. So we see here in each of the views that we can see the mechanical mitral valve, and we can see that it's moving a bit abnormally, what would be described as rocking. And what pathology would this suggest? Perfect, thanks, Fotis. So infective endocarditis and dehiscence of the valve. Thanks, Sean. Yeah, for sure. So in these echoes, we see rocking of the mechanical valve. Usually, we didn't have the color views in this previous case, but we can see presence of paravalvular regurgitation that would also support dehiscence of the valve. And then the sequelae, the sequelae of the regurgitation. So you can have, if it's prolonged, an enlarged left atrium or the right side of the heart. So the etiology is usually infective endocarditis, causing the dehiscence, basically, and the breakdown. And then if it's an aortic valve, there are other pathologies that can be in the differential, and these include an aortic aneurysm, calcification, or inflammatory conditions or vasculitides, but much less common. The most common is infective endocarditis. And management is, again, urgent CV surgical assessment in addition to appropriate antibiotic coverage. So another important pathology to recognize with echo, because it does change your management and require urgent CV surgical assessment. Okay, so those are the 10 cases, so it's a bit of an abrupt ending, but overall, I think in terms of our objectives, so we identified clinical situations that required urgent echocardiographic assessment, so undifferentiated shock of different etiologies, global LV dysfunction, tamponade, pulmonary embolism, mechanical complications of myocardial infarction, aortic dissection, cardiac ischemia, in addition to mechanical valve dehiscence. We described echocardiographic measurements that can aid in clinical assessment. So LV assessment, RV assessment and calculation of LVOT gradient, in addition to identification of vascular territories. And then we reviewed some pathology identified that would change management. I'm happy to answer any questions or probably throw them out to the team, because I don't know if I would have the answers, but if there are any questions, I'm happy to field.
So I just want to thank Carol for putting this such greatest hit of our on-call album today with the cases from our lab, and that we've seen over the months or years. And indeed, you know, interestingly, these pictures that you have shown are very limited, but yet, you know, with the integrated knowledge that you're going to have about the patient when you're doing on-call study, as well as hopefully the good physical exam before, and the images that you're going to get, to targeted images that you're going to get, we'll be able to answer questions that we deal with in an on-call basis urgently, and then sort of leading to the proper diagnosis. So you know, the on-call echoes really sort of required a lot of prior knowledge of the patient, and then you sort of integrating all this information, knowing actually what you're going to look for. So fortunately, you know, over the years, we have now put in a echo machine, the Vivid IQ at the CCU, so that's available to you when you're on call for CCU and the ward during the night and the weekends, as well as now many of us, especially Dr. Goffey and colleagues, have now carrying the POCUS machines that actually become the extension of our physical exam. So I think, you know, the world is keep changing. I think, you know, we still pride ourselves as Canadian physicians to be able to do physical exam well, and then, you know, using that coupled with our extension of our senses, including our stethoscope and our POCUS, I think together we can actually make diagnosis much more efficiently and more accurately, and, you know, directing the patients to go to have the right further tests as well as needed interventions. So with that in mind, any questions, comments?
My only comment, Carol, is those were excellent rounds. Very well executed. Thank you very much for your time.
Thanks, Otis, and thanks everyone who typed in the chat. I appreciate it.
Yeah, thanks everyone for participation. Very interactive.
Yeah. Perfect. I'm glad everyone enjoyed.